describe 5 types, and in essence, type 1 is repair of the drum or myringoplasty. Type 2 is the repair of the ossicles, and type 3 the same, a little bit more complicated with type 3. And then 4 and 5 are different. 4, the drum is directly on the oval window. 5 is a fenestration and the membrane is exposed to the world. So what we're talking about will be the type 1 myringoplasty and types 2 and 3. And we have Dr. John Sheehy from Los Angeles to thank for this, a simple way of remembering the priorities. That our first priority is to have a healthy ear. Doesn't matter about the hearing, doesn't matter about anything if you have a dangerous condition. You must have a safe ear first. Then what we would like to have is an ear that is closed to the outside world and therefore waterproof. That's a healed ear. And then the third priority would be to think about the hearing. Now, when we're talking about hearing and helping hearing, you think, why should it be the third priority? Well, we mustn't have a life-threatening condition that's left there. And in order to help hearing, very frequently we'll need a closed drum because we need to have something that will pick up the sound or something that will allow the patient to wear a hearing aid. So that's the order of the priorities. Healthy first, healed second, and hearing is third. The timing of the tympanoplasty, it may be done at the time of eradication of the disease, and traditionally we didn't do that. We did an operation to eradicate the disease, we waited, we did a second stage, and we did the tympanoplasty, the ossicular chain reconstruction at the second stage. There are very good reasons why we don't always need to do that. If there's not cholesteatoma, then we can clear the disease and do the repair. And if there is cholesteatoma, as Patricia said, we now have the second look procedure. It will help us modify how we follow these patients. And it may be that it's just a tympanotomy that is required. It may be that we do a canal wall up or a canal wall down procedure. And with any of those, we can repair the chain if it's required. If the disease is already controlled, then it may be a straightforward myringoplasty. We may do the myringoplasty and the ossicular chain reconstruction together. Or if the drum is already intact, we may just need to do the ossicular chain reconstruction. And this picture at the bottom here is a autographed incus, just a straight tympanotomy with no need for a myringoplasty. So the prerequisites. In general, we don't want to operate on an ear that is the only hearing ear. So we require there to be good hearing on the other side, and it may be good hearing alone, or it may be good hearing with some assistance. So such as an ear that can hear but needs a hearing aid. Generally, we do not operate, almost never operate on an only hearing ear just for hearing. It's acceptable and often necessary to operate on an only hearing ear if there is potentially dangerous disease, such as a significant cholesteatoma. But the rule generally is that we would not operate just for hearing on an only hearing ear. So we require there to be adequate hearing on the other side. And then we talked about on the operative ear, there may be disease, there may not be. We're aiming to, first of all, to get the drum closed. Secondly, to then have a dry ear, and if we can, surgically correct the hearing. It may be that there's a perforation and there's a fixation of the stapes. Well, we're not going to do an ossicular chain reconstruction on that. So the aim in that patient would be to have a closed, dry ear and then use a hearing aid for the conductive loss. The access can be via the canal, can be endoral, and it can be post-auricular. Via the canal, we can do it via the perforation or razor flap. The endoral and post-auricular approaches allow us to harvest some grafting material. And the methods these days could be endoscopic, it could be microscopic, or it might be a microscopic with endoscopic assistance. The techniques generally are an onlay or an underlay, or sometimes an onlay at the front and an underlay at the back. I didn't include small procedures like patching a little tiny perforation with a fat graft, not for this talk. And then the most common materials that we will use these days will be fascia and perichondrium. With perichondrium, when we take the perichondrium, we can take some cartilage as well. And then we can use a cartilage and perichondrial composite graft. That means the two are still joined together. Or we could use a combination of possibly fascia and cartilage, or perichondrium that's been separated from the cartilage as a combination. But if we can use perichondrium with cartilage still attached, and that's called a composite graft. And just quickly, why would we choose a cartilage graft? Generally it's thought to be stronger, less chance of recurrent, well, better in a recurrent perforation. If you use fascia and it's failed, then cartilage graft would be good. If there's poor eustachian tube function and tendency for retraction, then it's a good thing to put a cartilage graft in to prevent retraction. And if the ear is wet at the time you're operating, then it's a greater chance of success with the cartilage graft. Because it's rigid and fixed in some areas, it can prevent retraction if there's poor eustachian tube function, and it can replace bone. If there's bone missing in the attic or bone under the posterior canal wall missing, then the cartilage can allow you to repair that. And if we're going to use an allograft, a foreign material circular chain reconstruction, then we need to protect the drum with a piece of cartilage to prevent extrusion. And Mirko Toss put together a nice classification with 5 or 6 types of cartilage grafts. You can see there's a reference there. Now, if we then move on to a circular chain reconstruction, what are the prerequisites? Again, we don't want to operate on an only hearing ear for hearing, so we must have adequate hearing with or without an aid on the other side. Again, it may be that the ear is, the disease is controlled. And the aim with an auricular chain reconstruction is to improve the hearing. So we must have good bone conduction on this ear, we must have good speech discrimination with amplification, and we must have a mobile status. And the possibilities that we might encounter with the top ear, there's basically a straightforward perforation, a little retraction there, but a perforation, small perforation, and we can't really tell clinically what the ossicles are like. The hearing test may help us. With this one, there's a big retraction of the posterior segment of the drum, and the incus is missing, the oval window is here, that's the facial nerve there, and you can see that there's going to be, if we decide to repair that, lift the drum and put a graft in, one, we'd probably use a cartilage graft to prevent recurrence of retraction, and two, we're going to have to replace the ossicles because they're missing. And the possibilities of what we may find are here. It may be that the incus only is missing. It may be that the incus and the superstructure are missing. It may be that the malleus and incus are missing, and it may be that all of the things, malleus, incus and superstructure are missing. But if we're going to repair the hearing surgically, we must have a mobile footplate. And in general, the more that is still present, the better the result of the procedure. With minimal residue of the chain, the results are likely to be significantly poorer. Now, what are the types of auricular chain reconstruction? The first is a columella, which basically is a column of bone just sitting there to join the drum to the top of this baby's little footplate. An assembly is a little bit more sophisticated in that we have notches in the graft that will allow pseudo joints, if you like, that there'll be a little fitting of the malleus onto a notch, and there'd be something that allows the graft or the prosthesis to sit on the baby's head. So it's assembled, and there are joints, if you like, they're not true joints, but little joints between the graft and the existing ossicles. And in general, this is more stable because it's a little better locked, less chance of extrusion because the malleus is protecting it from that, and the results of hearing are generally better with an assembly. The choices are autograft these days. That's a patient's own bone. Here's an incus that's been drilled. This is the long process here has been drilled away and a notch is there. This is the short process and a little notch is placed there, and that notch is for the malleus handle, and this sits over the malleus head. We can then go for allograft designs made of all sorts of different things. Classically, we talk about partial and total prostheses, and there might be composites with metal and ceramic and so on. And the The reason there are so many grafts available on the market is that none of them is perfect. And again, I mentioned that if we're going to put something artificial in there, we need to protect the drum with a cartilage disc. And the ideals we're always seeking, we want the ideal material that is biocompatible and not risky. We want the best possible design, and we want very good technique. And all of us are still searching for that holy grail. So the predictors of outcome with singular chain reconstruction are the state of middle ear disease, the residual ossicles, what the hearing like on the other side, what's the hearing like on the side that we're operating on, and a couple of small things that can help. One is the Belfast rule of thumb, and the other, in assessing the result, would be the Glasgow benefit plot. There are predictors of better outcome, and they are that if the drum is already there and stable, if the malleus handle is still there, if the eustachian tube's good, if there's no adhesion to make scarring, if it's the first operation, if the canal wall is still up so the anatomy otherwise is normal, a good technique, then all of those things predict a better outcome. The Belfast rule of thumb essentially says that if you can get the air conduction up to less than 30 dB average, or if you can get the air conduction up so there's less than a 15 decibel difference between the operated ear and the other ear, the patient's likely to be happy. Just quickly, in working out the pure tone, most of us would use 500, 1, 2 and 4 hertz. The American Academy uses 500, 1, 2 and 3 hertz, so you need to be careful when looking at data and reporting. Now, in reporting outcome, one of the principles of the procedures is to look at our outcomes and learn from them. We could ask what the patient says. Do you hear better? Yes. Is the hearing socially adequate, meaning that the pure tone is 30 or less? You can look at the level of the pure tone average and the speech scores. You can look at the size of the air bone gap that's still there. You can measure how much the air bone gap reduced from before to after the surgery. You can look at any reduction in bone conduction or speech discrimination, which essentially are a complication of the surgery. And there is this thing called the Glasgow benefit plot, put together by George Browning and team in 1991. Essentially, this is it. You can look it up. I won't go through it in too much detail, but basically, it plots the pure tone average of the operative ear and the non-operative ear. Two bad ears are going to sit here. One bad ear is going to sit here, and what you're trying to do is get that poor hearing down into this better level. It all looks at 30 decibels, talking about social adequacy, and both ears are plotted. The possible improvements are just as the green, moving them from, we're talking about the operative ear, here's the operative ear here, poor hearing is up here, and we're trying to move it down into better than 30 dB. Here's a case that had bilateral conductive hearing loss due to chronic otitis. The left ear is the worst ear. We plotted that on the plot, and we saw that both ears were down. Here's the preoperative level, and we're hoping to get it to this level. Fortunately, there's the result at a year, and that shows that the conductive component is markedly reduced. And when we plotted that out, we actually got it from the poor level down to here. But note that the hearing on the other ear, on the non-operative ear, is still poor, and there'd be a case for thinking about whether the second ear could be done. So in summary, case selection is important. We have to give due consideration to middle ear disease, whether it's cholesteatoma or chronic other suppurative disease. We should think about the likely ossicular status, what we can see on examination of what we see with the hearing. We need to know what the hearing's like in the operative ear, and clearly we must know what it's like in the contralateral ear. We must assess the patient properly, imaging if necessary, and then the reporting tools are the Belfast rule of thumb we've talked about, the benefit plot, and don't remember that a good result early doesn't always remain long-term, so long-term follow-up is required. Thank you very much.